Hello everybody, welcome to tutoring for week 5. We are going to be reviewing some concepts from chapter 7 on high risk antepartum nursing care. So as discussed in our lecture, we talked about preterm birth. There are an array of things that can cause preterm birth. One of the major risk factors is having a history of preterm birth when women are carrying multiples, whether it's twins, triplets. It can also lead to preterm birth because of the stretching of the uterus that causes the production of prostaglandins, okay? So make sure that you go back and review all the risk factors for preterm birth. Remember, whenever we suspect a patient is going to go into preterm labor and ultimately preterm birth, we want to try to hold them off we administer an array of different tocolytics such as terbutaline or breathine. Excuse me. That is a tiny little injection that's done subcutaneously. Remember, it leads to maternal and fetal tachycardia. So when you are administering this medication or before you administer this medication to your patient, you need to make sure that you educate them and let them know that they're going to get, palpitations, that they might feel a little nervous, a little antsy or anxious because they'll be laying in bed experiencing palpitations. So make sure that we provide education. It will also cause tachycardia in the fetus. If you have a client who has or suffers from tachycardia, this is probably not your tocolytic of choice, okay? Because it's going to exacerbate the problem and it's not something that you want to do. So keep that in mind. If we're assessing a patient, let's say they have a history of preterm labor and they're coming in and they're complaining of contractions, because they already have a history, we know that they're a high risk. We want to do different tests. We talked about this as well. What test are we going to do? We can do a transvaginal ultrasound to measure the length of the cervix. If it is less than 20 millimeters, then they are a high risk for delivering preterm. If it's more than 30, then we're not so concerned. We also do a phytofibronectin test, where we check the fetal fibronectin levels. This test has a good negative predictive value. What does it mean? It means that if the test comes back negative, chances are that woman will not deliver, at least not within the next 2 weeks, okay? So keep that in mind. Again, when we administer terbutaline, when we administer endomethacin, procardia, any of this, remember there are side effects with those, and that you have to see which one is appropriate for your patient according to their comorbidities if they have anything. We also do this to hold them off for about 24 hours to be able to give them betamethasone or dexamethasone or whichever corticosteroid to help with the lung maturity of the neonate. Okay, so we generally administer one dose, and 24 hours we administer a secondary dose. So keep that in mind. That's one of the reasons why we want to administer tocolytics, to allow for the administration of betamethasone to help the baby's lungs mature. When we administer magnesium, while it's on your book as a tocolytic, we now know, and it says it on that table as well, it is no longer used as a tocolytic, but it is used for neuroprotection of the baby. When we administer magnesium for preterm, the idea is to provide neuroprotection for the baby. When we administer magnesium because of hypertension, we are actually attempting to prevent, for example, a preeclamptic patient from becoming eclamptic. How do they become eclamptic? 2 ways. They can go into a coma or they can develop seizures. So the goal of the magnesium is to prevent that. It also does help, since it's a smooth muscle relaxant, it can decrease a little bit the contractions and help the vessels to relax a little, but that is not the goal. Okay, that is not the ultimate purpose of that. When we are administering magnesium, whether it's for preterm or preeclampsia or hypertension or whatever the reason may be, we want to monitor for mag toxicity. Remember, you must always have calcium gluconate on hand. That is the antidote for toxicity. Therapeutic levels, we know your book says 4 to 8 or 5 to 7. Let's, just keep that in mind. Magnesium, it can cause urinary retention. It can lead to loss of deep tendon reflexes, respiratory depression, and etc. So keep that in mind. Those are the things you're going to be looking out for in order to manage your patient who is on magnesium. If you find any of these, you're going to have to call the provider and make sure that that you notify them, because it could be that they have developed mag toxicity. Remember, we treat the patient, okay? When we are dealing with a client who has gestational diabetes or some sort of diabetes, okay? Diabetic patients tend to have macrosomic babies. What are macrosomic babies? Babies that are larger than 4,000 grams, okay? They also tend to experience polyhydramnios or hydramnios, which means abundant amounts of amniotic fluid, okay? So we need to keep that in mind. These patients many times have to be induced, okay? They have to be induced because the babies are just getting too big. So we want to monitor for that. When we are treating a patient that maybe did not have, chronic, or type 1 or pre-existing diabetes, we do a glucose tolerance test, all right? The first glucose tolerance test, they receive 5 grams of oral glucose, and an hour later we do a test. And if their glucose levels are above 140 milligrams per deciliter, we schedule them for a secondary oral glucose test, or OGTT, oral glucose tolerance test. The secondary test, remember, only occurs if the initial one has results of 140 or above. When we do the secondary test, the patient has to be fasting for a minimum of 8 hours, ideally 12 hours. So they have to come in fasting. We do a fasting glucose. If it's above 95, they get a strike, okay? Then we administer 100 grams of oral glucose, and then an hour after that, ingesting that, we check their glucose. And if it's above 180, we are concerned. That is the first one. They would get a strike. Secondary would be above 155. And the third, if it's above 140, they would get a strike. So how many strikes do they need during that secondary test to be diagnosed with gestational diabetes? 2. So if 2 of those glucose levels are above the parameters that have been set, then they would be diagnosed with gestational diabetes, all right? So at 3 hours, if it's above 140, they get a strike as well. If fasting, they have above 95, they get a strike as well. So 2 out of the 4 tests that you do during that secondary test, you have to, they would be diagnosed with gestational diabetes. Initially, we treat these patients, or we attempt to treat them or manage them, better yet, with diet alone. If that's not working, we do multiple treatments, but mostly they put them on an insulin sliding scale, okay? So depending on where their glucose is at, they'll administer X number of insulin units. Keep in mind, when we have patients, remember in pregnancy, our HCG levels go really high, up to the point when you're 12 weeks. After 12 weeks, when the placenta takes over, HCG levels decrease. However, in patients who have hyperemesis gravidarum, these patients, their HCG levels don't really drop, okay? And they continue having nausea and vomiting to the point where they can't keep anything down, all right? They vomit every single day. They can't get out of bed without ingesting something. They shouldn't get out of bed because it decreases their chances of vomiting. Some of them have to be hospitalized to be given IV hydration. They have to go on like pumps. There's a whole bunch of complications. Please note that we don't really know what causes hyperemesis gravidarum, but we know obviously is related to the pregnancy hormones. Also, patients with a history of H. pylori, okay, are more likely to have hyperemesis. And then patients who are experiencing really high levels of stress, maybe it's an unwanted pregnancy, maybe they're going through a divorce, maybe they had a loss in the family, whatever emotional stress, that can actually lead to hyperemesis gravidarum, so keep that in mind. Let's talk about vaginal bleeding. Remember, if your patient has vaginal bleeding, you do not perform a vaginal examination. What can cause vaginal bleeding? Number 1, placenta previa. It means the placenta is covering the exit. It is covering the os. And so any maybe heavy activity, intercourse, all of that can cause vaginal bleeding. If your patient comes in, chances are they already know they have a diagnosis of placenta previa. You would want to still confirm it with an ultrasound. And you would not perform a vaginal examination because your fingers are going to go right to the placenta and you're going to exacerbate the issue. Patients with placenta previa must be taught that if, number one, they have to go on pelvic rest, and number two, that if they start experiencing bright red vaginal bleeding, they must notify their provider because they can hemorrhage. So we want to make sure that we educate our patients once they've been diagnosed. The other cause for vaginal bleeding is placenta abruption. Remember, this is generally due either to trauma, high blood pressure, or drug abuse, all right? People who use cocaine, a lot of times, remember, this causes your blood pressure to spike, and it can cause the placental detachment. Please note, previa is painless, bright red blood. And abruption, it is painful red blood or dark red blood, and the abdomen becomes board-like, okay? Really, really rigid because the body goes into, oh my gosh, I'm going to hemorrhage. Let me just contract so that I don't hemorrhage. Remember, when the uterus contracts, the vessels constrict. So that's the idea. That's what the body's trying to do. In the meantime, you have a baby in there who is not doing well. So it is an obstetrical emergency. There are different degrees of detachment. Some of them, if you have a 5% detachment, and if it's in the center of the placenta, it'll develop like a hematoma and it'll stop and everything will be fine. You just have to monitor this patient really closely. However, for the most part, if you're abrupting, it requires an immediate intervention, which would be a cesarean section. So keep that in mind, okay? Patients who have a molar pregnancy, okay, or gestational trophoblastic disease, GTD. These are patients who don't have a true pregnancy. They have a molar pregnancy. Remember, it's a malignant condition. They have grape-like clusters in the uterus, but they will test positive in a pregnancy test because their HCG levels are very, very high. A lot of these women have to be treated with chemotherapeutic agents once the vesicles or the cluster-like grapes that they have in utero have been taken out, extracted. We need to know these patients also have vaginal bleeding. What kind of vaginal bleeding? Remember, it's brownish, dark red, or prune-like, like prune juice-like bleeding. So we need to monitor those patients. The other thing that can cause vaginal bleeding too is an ectopic pregnancy, a ruptured ectopic pregnancy. Patients will usually complain of unilateral pain, lower abdominal unilateral pain. You have to ask them, when did you last miss your period? If they tell you, oh, I'm 2 weeks late, chances are it could be an ectopic pregnancy. If it is ruptured, as the blood pools, it compresses the phrenic nerve and it can cause referred shoulder pain. Keep that in mind. When we are dealing with patients that have preeclampsia, okay? Preeclampsia is a multi-system condition, all right? It's not just elevated blood pressure, all right? It's not just elevated blood pressure with proteinuria. In fact, proteinuria now, it's like a non-factor. We want to look at their liver enzymes, AST and ALT. If they are elevated, we are concerned. The other thing that can happen is these patients with severe preeclampsia or eclampsia can develop HELP syndrome. What is HELP syndrome? H stands for hemolysis. EL stands for elevated liver enzymes. And LP, the last, because it's HELLP, the LP stands for low platelets. So if you're caring for a patient who has preeclampsia or eclampsia or had it, and maybe even if they're postpartum, you want to monitor not only their liver enzymes, but also their platelets. So platelets will drop, liver enzymes will go up. They will increase. Keep that in mind, okay? Patients who develop HELP syndrome are at risk for multiple complications, including death. Their liver can actually rupture. They can also have, if they're still pregnant, they can have a placenta abruption. Remember, all of this is related to really, really high blood pressure. So if your blood pressure goes really high, absolutely, your placenta can detach. So keep that in mind. When a woman has a baby, okay, the physician will always look at the placenta After the baby's born, when the placenta is delivered, they will look at the placenta, and they look at it to check the placental grade, to see if there's any calcifications, to see if you see that there's a big chunk missing from the placenta, chances are you have retained placenta, and so they have to go in there and scrape it up from the uterus, because if it is not removed, it'll lead to postpartum hemorrhaging, which is one of the main reasons why they check the placenta. They want to make sure they have it complete. Now, they also, let's say you have a patient who had high blood pressure and she was fine, and all of a sudden on the monitor you see your baby go south, it could be that she had a placenta abruption. So when she delivers the baby, you're able to look at that placenta and see and confirm if there was an abruption of sorts. You would be able to see it on the maternal side of the placenta. Same way we have preterm, we also have prolonged rupture of membranes, which can occur. This happens when women, their water breaks, their membranes rupture, and they go for a long period of time still, in labor, and they don't deliver. Remember this, the membranes are what keep the baby in a sterile environment. Once that is ruptured, you increase the chances of developing an infection that we call chorioamnionitis. All right, so these are things that we need to look out for when we have patients who've had prolonged rupture of membranes. When we have these type of patients, we want to minimize the number of vaginal examinations that we do. We would only go in there and do a VE if we find it, that it's absolutely necessary. You're not going to just be checking every hour just to check how your patient is progressing, because you increase the chances of them developing an infection. Okay. Patients that have any type of hemorrhaging or bleeding, whether it's from an abruption or an ectopic pregnancy, always are at risk of developing disseminated intravascular coagulation, or DIC. Okay, these patients, what is the treatment? Yeah, we want to find the root cause of the hemorrhage and we want to stop it. Absolutely. But just as important, we may want to hemodilute these patients. What is hemodilution? We give them a bolus of a lot of fluids. Why? Because even if they're losing blood, the amount of RBCs that they're losing is going to be less, because you are diluting the blood. Okay, so they are, remember, at risk to go into hypovolemic shock as well, because their blood pressure is going to go down, their heart rate is going to go up, the body's trying to compensate. So just keep that in mind. When we're caring for patients who have HIV, remember, at 36 weeks, the physician is able to determine if this patient can attempt a vaginal delivery or not. If they have less than 1,000 copies of the virus at 36 weeks gestation, they can have it. If they have been taking their antiretroviral meds, the chances of transmission are only about 2%. Now, if they're not taking that, it could be up to 25%. Remember, when we care for these patients, we want to minimize the chances of them requiring either an episiotomy, an operative vaginal delivery, which means the use of forceps or a vacuum, laceration. So we want to allow the patient to progress relatively slowly so that we can minimize the need for any of these procedures when we're delivering a patient with HIV. Remember, they cannot breastfeed because HIV crosses into the breast milk. So remember that. Remember the gifts that keep on giving: HPV, HSV, and syphilis. All right. We cannot be protected from those because they are contact. However, you can educate your patients on the different methods that they can use to protect themselves somewhat from STIs, like using a condom, okay? It decreases your chances, but it doesn't eliminate every single, STI. Urinary tract infections in pregnancy are a big deal. Remember that. They can start having contractions, and they can actually put a woman into early labor if it is not treated, okay? So you need to monitor. When your patients come in, I always say it, patients come in into the hospital and they're contracting, it's one of two reasons. They have a UTI or they're severely dehydrated. And most of the times, those that keep on coming back because they're dehydrated, they don't drink enough, they usually end up with a UTI. So we want to make sure that we address this. UTIs are one of the main reasons why women go into labor early in the process, okay? When we have patients with HSV, if they have active lesions, they cannot attempt to have a vaginal delivery because they will give it to the baby, and we want to prevent that. All right. So remember that the chances of transmission are a lot higher if the woman is experiencing the first outbreak ever, if she's being diagnosed during her pregnancy. Okay, let's say she's about to give birth and now at this moment she's being diagnosed, the chances are a lot higher. If she's coming in for a vaginal delivery and you find that they have active lesions, if you inspect and then externally they have some lesions that you're able to visualize, you will notify the physician because that patient cannot have a vaginal delivery. Patients with GBS, you want to make sure that you give them antibiotics during the labor process. They need to have antibiotics on board at least for 4 hours. Okay, so as soon as they get there, if you know they're GBS positive, you need to administer antibiotics. Let's see, genital warts is another one we talked about. Genital warts, just because you have genital warts does not mean that you can have a vaginal delivery. Unless they have really large condylomas where it's blocking the passage of the baby, they can have a vaginal delivery. They do not require a cesarean section only because they have genital warts. Review, please, some of the signs and symptoms that show us for patients who have congenital heart disease. During pregnancy, remember our blood volume increases significantly. So it can exacerbate some of these symptoms in patients who have congenital heart disease. Please review that. They can usually have syncope episodes, arrhythmias. They can become cyanotic, you know, all kinds of things. So make sure that you review the signs and symptoms that show that the condition is worsening as a result of the pregnancy, the increased blood volume, etc. Patients who use drugs, we want to know. Cocaine, remember, major cause for abruption. Cigarettes, major cause for low birth weight babies who later on in life actually develop obesity. Okay, patients who are on opioids, these are the ones that come in complaining of pain because they want opioids. They want you to medicate them for pain. Okay. And you will find these patients are non-compliant. They usually look a little groggy. Most of them don't have any prenatal care. And if they do get prenatal care, it's usually late in the game because they know that the physician is going to be able to identify that they have, that they are abusing opioids. This is a huge problem in our country today. We have an opioid crisis, okay? Know the definition of what an abortion is versus a fetal demise. Fetal demise is when the baby passes in utero. An abortion is when the baby is expelled, whether alive or not, but it has to happen before they are 20 weeks gestation. Remember, placenta accreta, increta, and percreta. According to the alphabet, it gets progressively worse. Please note that patients who have cesarean sections have increased risk of developing placenta accreta. And the more C-sections you have, the higher your chances are. Whenever we have a patient, if they come in, if you're in the ED and you have a pregnant woman who just had some type of trauma, remember this, we want to save mom first, okay? Because if mom is not well, you know who else is not going to be well? The baby. So we aim to save mom or to help mom. It doesn't mean that you're only going to take care of mom and then think that the baby's only going to be an afterthought. No. But your priority is the mom. Generally, you start treating mom and immediately you're calling for an ultrasound and somebody's trying to assess the baby, see if there's an abruption and all of that. But your priority really is stabilizing mom, because if you stabilize mom, you can stabilize the baby through mom. All right. Again, really quick, patients who have high blood pressure, you need to keep an eye out when you have to see, is it getting worse? How do we know? When they are progressing, they develop signs like, you know, blurred vision, double vision, or they can start developing epigastric pain, headache that's not relieved by medication. So it means it is worsening. They can go from having just, you know, chronic or pregnancy-induced hypertension to preeclampsia, which is multisystemic. Remember, it's not just the blood pressure. Now it's affecting the liver. It's affecting your platelet count. So just keep that in mind, that as blood pressure issues or hypertensive disorders progress, you have more signs and symptoms. So I strongly encourage you guys to please read your chapter in its entirety, review the lecture, and go back and make sure that you understand all these concepts that we have discussed. Thank you.